Good evening. I'm Sherry Shelton. I live in Fort Worth, Texas. A trophy club that's right in the middle between Fort Worth and Dallas, Texas, and I'm doing my PowerPoint, going over that for quality improvement. I interviewed Mr. Palmore at my facility, Baylor Scott and White All Saints in Fort Worth, Texas, and we went over to discuss the quality improvement that Baylor has in place. So the assessment of the facility would include recent concerns that our facility has would be adverse event reporting, hospital-acquired pressure ulcers, falls, hypo and hyperglycemic events, improving handoffs when you're given report to another department, lab recollections when the lab has to come and recollect a specimen, or people that have left without being seen, which is against medical advice. Also, medication administration errors are a problem, patient flow, and then transferring to a higher level of care. So the top two facility priorities would be falls and patient flow. So falls are a prevalent safety problem, and any patient or physical ability could be at risk for a fall based on their condition, their medication, if they've had surgery, any procedures or diagnostic testing. A fall could result in a fracture, laceration, or internal bleeding. This increases the healthcare utilization, and research does show that close to 1/3 of falls could be prevented. So the QI initiative and its importance would be you want to manage the patient's underlying fall risk. You want to optimize the hospital's physical design and environment and increase patient safety. So with that said, the evidence used for determination would be the IHI, the Institute for Healthcare Improvement, and the NDN-QI is a national database on nursing quality indicators. The IHI is an independent, non-for-profit organization, and it's the leading innovator of healthcare improvement worldwide. The IHI focuses on 5 key areas. The first one would be improvement capability. The second one would be family and patient-centered care. The third would be patient safety. The fourth would be quality, cost, and values. And the fifth would be the triple aim for populations. The NDN-QI is a national database, and it delivers evidence to support the importance of nurse-sensitive measures and overall patient experience strategy. The Press-Ganey Nurse Excellence Solution combines the NDN-QI quality indicators with patient experience and nurse engagement survey data. It's going to provide the nursing leaders with a single comprehensive source of insights. The next thing that we will go over is the perspective of impact and facilities mission. So a measure of whether or not we're compliant with performing our interventions would help us have whether or not this is how it's impacting our facility. Our mission statement at our hospital is that we exist to serve all people by providing personalized health and wellness through exemplary care, education, and research as a Christian ministry of healing. The FMEA guidelines, FMEA stands for Failure Mode and Effects Analysis. It identifies and eliminates the process failures for the purpose of preventing an undesirable event before an adverse event happens. The RCA, which is your root cause analysis, it's going to address the problem after it occurs. So when we take a fresh look at fall components, we would consider physiological, structural, process, education, executive, and monitoring. So the goal of our proposal was for within a 1-year time frame from June the 30th, 2017 to June the 30th, 2018, that we would have a decrease in the number of falls per month from 26 to less than 15 falls per month. The national standards are met by addressing the initiative through the NDN-QI. You also have your Hospital Acquired Condition Reduction Act and value-based purchasing. The Affordable Care Act requires that for Medicare and Medicaid to reduce the hospital payments by 1% for hospitals that rank among the lowest performing 25% in regards to hospital-acquired conditions. It ties performance and safety issues such as infections, blood clots, bed sores, and your post-op care to the payment, how much payment the hospital will receive. The law requires the CMS to post publicly the hospital's performance on hospital-acquired condition, the quality measures. The quality indicators that are used to measure this improvement would be you want to be compliant with your fall risk assessment, your fall precaution interventions being in place, your hourly rounding with the 5 Ps, and I'll go over that, and your delirium screening and the screening for orthostatic hypotension. So with your 5 Ps, the first one includes pain. You want to assess the patient's pain level and medicate them if needed and it's time to. The second one would include their personal needs. This would be like offering to help them go to the restroom. Make sure that they have hydration, water, and nutrition when needed. The third one would be position. You want to make sure that the patient is in a comfortable position. And if they're bedridden and can't move on their own, you want to make sure that you're moving them every 2 hours to prevent skin breakdown. The fourth P would stand for placement, and this you want to make sure that all their essential needs are in reach. They can reach the nurse call light and they have their phone in reach. And lastly, the 5th P would be to prevent falls. And you want to do this by asking the patient to use the call light if they need to get out of bed or need help getting up. The quality indicators supportive of the initiative would include you're going to have an increase in patient satisfaction, a decrease in the length of stay, and a decrease in your sentinel events. On data collection, our magnet coordinator and our informatics pulled information from our electronic health records. They benchmark against other hospitals using the NDNQI system, and they have process measures that trend over time just for our specific facility, which is Baylor Scott and White All Saints in Fort Worth. The agencies that information is reported to is Medicare, Leapfrog, and Medicaid. The interprofessional collaboration is nursing involvement is going to be 100% to support the goal and the reduction of falls. There's a team approach with 16 members, including your CNO, several department managers and staff RNs, and you're going to have your nurse educator involved. Other staff involvement is you're going to have your float staff. Possibly your physical therapist will work with the nurses to discuss the patient fall risk. Any staff that notices anything wrong, all of your agency nurses, and any contract workers, which in our facility, an example would be your anesthesia staff. Some challenge barriers would be an increase in patient census. Another challenge or barrier would be having less staff available, or the fact that the patient may be non-compliant. The nursing recommendations to alleviate these challenges, you just want to explain the care to the patient, orient them to the unit. They may be on a medication that increases their fall risk, so you want to have them call for help. Some other recommendations to alleviate these challenges would be to have sitters sit with them or implement the bed alarms. Involving others would be your executive sponsor, like your CNO. Your physician champion would be your physician. Your informatics would be your critical care, education, and pharmacy director. The managers would come from risk management, an RN, biomed, and the HCI department. You're going to have your physical therapist, occupational therapist, and your patient safety officer. The other departments that can assist with these modifications is they can float staff. They can communicate with other departments involved in the patient care about the fall risk. We also have town hall meetings, huddles where each department has a huddle before, during, or after their shift to talk about what's going on that shift and things to implement to make it better. We have unit-based councils at our hospital and a nurse executive committee. We have professional nurse engagement and the empowerment council also. So involving other departments, you want to speak with a department supervisor or manager about the work that's been done so far and to ask for suggestions on how to include them into the work. And with this, the timeline and budget, the timeline was from June the 30th, 2017 to June the 18th, 2017, 1 year. The CNO is the person that sets the budget at our hospital. And they also require, with this budgeting, is mandatory staff training and development to get this off and running. So modification accomplishments would be your staff training and development. You're going to have a decrease in the number of falls and injuries. You're going to have an increase in safety precautions proven to help. And we want to be in the top 25% performing hospitals in the nation for falls. And also our outcomes can be evaluated through a continuous sustainment quality improvement plan. We want to monitor and hardwire the process changes by performing audits and providing real-time feedback. And with all of this, we hope that we can and will be able to get falls down to a very minimum. We have a floor B4 that bought a system, the CNO, through our budget of video monitoring. So now there's video monitoring that goes on in the hallway as we use this also as another means to decrease falls within our hospital. Thanks and have a good evening.